Hello, and welcome to the GoLIVE Health Foundation Women at Health webinar series. Thank you to all of the sponsors of the series. Today's episode is brought to you by our friends at ZS. We would like to remind you that the Q&A feature is available, so feel free to send in your questions throughout the discussion. And with that, I will turn it over to our moderator who joins us from ZS, Maria Whitman.
Welcome, everyone, and thank you for joining us today. We're here to discuss a better future for women's health. In a study I did this year with 4,000 citizens in the US and their doctors, I was looking for how patients are experiencing healthcare overall. And what I found was striking differences in men versus women. Women are statistically more likely to describe negative experiences or describe their experience with negative connotation, feeling less heard, less cared for, and in many cases, more disconnected than men. They are statistically likely to have less trust in the healthcare stakeholders that are actually providing their care. And as a result, they're also statistically less likely to be sharing the data and the information that is actually valuable to their personalized healthcare. Experience is only one thing, but it's complemented with a growing body of outcomes evidence that the care women receive has tremendous disparities in it, whether it's women versus men in surgery or women versus other women experiencing equity and determinative health barriers in categories like breast cancer. This is not a moment for discussion. This is a moment for action. And that is why I am so thrilled to be joined by an outstanding panel of women. These women are leading the charge in their respective fields in redesigning healthcare for women. Lori, Allison, Carolyn, thank you so much for joining me today. I'm going to ask you to each introduce yourselves. And as we do, let's dive right into the action. Let's talk about what you see as the biggest gaps that we need to close as we redesign healthcare for women. Lori, I'm going to ask you to go first.
Sure. Thanks so much. It's really an honor to be on this panel with everyone, and thanks, Maria, for leading this panel. Lori Zephyrin, I'm Senior Vice President for Equity at the Commonwealth Fund. We're a foundation and a think tank. In my work as a clinician, OBGYN, working in health systems transformation and policy, and now in philanthropy, a lot of my work is focused on how to make the systems better for the people that are in them. So in terms of your question, most important gaps to think about redesigning healthcare for women, there are many. One around increasing coverage, ensuring that birthing people are heard and have a voice in decision making, and expanding and diversifying the workforce, and ensuring that we're providing the highest quality care across primary and maternal health.
Wonderful. Thank you so much for that. Allison, how about you? You're on mute, Allison.
I think I'm off.
There you go.
Okay.
Oh, we lost you again.
I'm not on mute.
There you go.
Okay. You lost me.
Yeah, there's something going on. Well, should we pop to Carolyn and then we'll come back? Okay, Carolyn, why don't you go ahead?
Hi there. It's great to be here with some these amazing panelists that I'm very motivated to work alongside in terms of furthering our mission for improving women's health. I'm Carolyn Whitty. I'm the co-founder and CEO of TIA. TIA is the Modern Medical Home for Women, a hybrid virtual and in-person care delivery company that provides comprehensive care for women puberty through menopause for their whole health, physical, mental, and reproductive health. And our vision really is to create a new healthcare system that centers on the experiences of women and shift. You really ask the problem that we see, many problems, but perhaps above all else, what we really see and aim to solve is shifting from the healthcare system, thinking of women's health as niche, as a body part or a life stage, and instead reimagining what care delivery is for women, for 50% of the population as whole people, physical, mental, reproductive health care for their whole lives. And that's really what TIA aims to do as a by women, for women care delivery company.
Wonderful. That's great. Thank you. And while we're waiting for Allison, maybe I'll just introduce her quickly as oh, there she is. Allison, would you like to introduce yourself? Go ahead, Allison.
Okay, hopefully this works. Okay. Great. So I'm Allison Mcgregor. I am a professor of emergency medicine and currently the Associate Dean of Clinical Faculty Affairs and Development at the University of South Carolina, Greenville School of Medicine. I've spent my entire academic career really trying to understand these issues that we're discussing today. And so I love the fact that we're discussing this. The biggest gap that I see, which is not small, is that we really need to make sure that research takes into account women's unique physiology across the entire lifespan. So that means including our understanding of our hormonal changes, prepubertal, our monthly cycling, postmenopausal, and really all of those changes that occur during pregnancy for women as well. So there's a lot of work to be done, but I'm confident that more discussions like this will lead to action.
So you highlighted among the three of you that we really are lacking in full access to our whole person care that is personalized to who we are and what we're experiencing physiologically, and with good experience. So these seem like the basic rights of healthcare in many respects, and yet they've remained disconnects for a long time. So what are the gaps? Like why are we not able to close these gaps so far in health? How about Allison? Would you like to begin?
Yeah, perfect. I think there's a couple issues there that make it so challenging. One is the lack of awareness that that women and men have unique needs for healthcare. Also, the fact that it's a very complex system when you think of healthcare. It's from research, making sure that discovery and policies around inclusion and analysis, making sure that that's up to date, including. And then all of that information has to get brought into health education. So the faculty development to be able to teach the faculty that there are new understandings of health and disease, and that all of these taught to our students and our future care providers immediately. There's the clinical practice, and all of that has to occur before we can actually make these changes when we're seeing patients. So we need clinical practice guidelines to be able to very complex system that really needs everyone.
Allison, I appreciate that. We're still having a little issue with your audio, but if I can summarize for the audience, I think a lot of what you're talking about is that at the very core, it's not just about the decision when the patient is in front of you in the treatment. It goes all the way back. It goes back to how we study and produce new medicines and treatment protocols. It goes to how we educate physicians at the earliest levels about the differences in each other. And then it's about the practice itself and how do we bring those to life in our everyday search for care for the person, not just you know, as a full body entity. I'm gonna pass it over then to Carolyn. Do you want to go next?
Sure. I will just sort of layer in there to talk about really the concept level, a problem, I think, about how we conceive of what is women's health in this country. As I mentioned a few minutes ago, I think we think of women's health as a body part or reproductive life event. And as a result of that, I think we've largely ignored care for women as whole people and our understanding of sex-specific difference from the research stage to the medical school stage, as Allison mentioned, to the way we diagnose and treat women. And I think as we shift our healthcare ecosystem to recognize this type of sex-specific difference and think about the needs of women as whole people, we present an opportunity to personalize care delivery, to better diagnose and treat women, to deliver women a better experience that gets women healthy and keeps them healthy.
Absolutely, absolutely, and you and Allison have some similar thoughts on that. You know, it's you know, women are not just men with different body parts. We are quite different to begin with, and we have to start there. Allison, to quote you directly, we're not men with boobs and tubes. Lori, how about you? What do you think?
Yeah, I think it is a great question, and I would agree with the sentiments around you know, we're more than just sort of, you know, our parts along the quote unquote bikini line. I also want to dive a little deeper. I mean, you talked about some research. in your opening, Maria, just about, just some of the data that you looked at. At the Commonwealth Fund, we also did some analyses just looking at healthcare and women here, comparing it to healthcare women in other high-income countries, and not only showing that the United States, we have the highest maternal mortality rates of other high-income countries, showing just US women are sicker and more stressed and die younger compared to women in other countries. And there are a number of reasons for that. And, and sort of part of underlying, I think, what Allison and Carolyn sort of discussed is just really an underlying underinvestment in women's health, an underlying underinvestment in healthcare. We have an inadequate primary and preventive healthcare system. I know we're going to talk about that later. That really partially explains some of the inequities and disparities, gender and racial and income, that we see in not only maternal health, but also in other outcomes as well. And when we look at women of reproductive age, for example, we spend more on healthcare. Women have higher out-of-pocket costs. On average of $2,000 more, for example, compared to women in Australia or Canada. People have problems paying for their healthcare bills, don't have access to a primary care condition, have more chronic conditions. And so all of it lies to an underinvestment in our healthcare system, and a healthcare system that really takes into account gender needs and gender and racial equity.
And, that's so striking, especially when you think about Carolyn's vision that she talked about, highly personalized care. We're talking even about baseline infrastructure not being set in place to support us before we can even get there. And so I think we have to take a moment now to talk about the elephant in the room. So we're here to talk about advancing women's health, and you're talking about baseline care, and yet we just had an historic striking down of Roe v. Wade. And increasing level of abortion restrictions we see happening in states across the U.S. Now, each of you have actually written about this topic and the consequences not only to women but to the healthcare system. So I'd like to hear more about it. But Lori, let's come back to you for a second. You've done so much work in maternal care and in maternal mortality. Talk about these consequences for women, but also for the system at large.
Yeah, the consequences are severe. I mean, when we think about just, this shifting landscape, right? We're living through, I say, a collision of crises with COVID-19, public health emergency, economic pressures on people's daily lives, and a Supreme Court decision designed to end the right to safe and legal abortion. We know that these actions will further compound the crisis that we see in maternal health, particularly for Black and Indigenous people as well. It'll reduce access to healthcare for women of reproductive age, make it less safe for all birthing people to access healthcare. And then also there's the workforce issues as well. And, so what we're seeing is really a ripple effect or a shockwave that this will provide through the American healthcare system. We like to silo things out and say, this is just about abortion care, but abortion care is part of comprehensive reproductive health care, which is part of comprehensive health and primary health care. And we know that those systems are fractured. And so we're adding this decision on top of an already fractured healthcare system. I think just a couple of other pieces that I think it's important to highlight is, this decision not only will deepen inequities, it'll also reduce access to care by making reproductive services inaccessible to many women and families across many states, providing fewer options. There's just the workforce implications are huge. I'm happy to talk more about that, but we've heard about people with miscarriages or ectopic pregnancies and not being able to access healthcare. And then on top of that, creating fear and anxiety, in addition to the thousands of unplanned births on an already fractured system. So this is a real dire emergency, and we need to address it as such.
Thank you so much for that. And Carolyn, I know, as CEO of a company, you've been having to adjust and think about the ramifications even for your platform and for the people in your care. What are you seeing and thinking about?
Yeah, so I'm going to play the role of trying to talk about solutions, building on the problems that Lori articulated are, I think, very clear and, a devastating loss for women's health, women's rights, bodily autonomy, so many things. But the role that I really tried to play not just in the last couple of months, but actually the last year, as Tia's team has really been preparing for a post-Roe America for some time, accepting that this was coming. It was just a matter of when, and saying, okay, what are we going to do about it? We're responsible for patient care. We employ providers who want to deliver comprehensive reproductive health care. How can we do that in this new world? And so while there is, I think our strategy has been, let's not try to focus our efforts on saving Roe, but shifting the conversations from just policy in the courts to the exam rooms, and really leaning on medication abortion, specifically medication abortion in a primary care context, as a way forward. I want to call out that there is no silver bullet here. This is extremely complex problem that requires a multifaceted solution, but do believe that primary care, specifically women-specific primary care models like TIA, have an opportunity to address the supply gap that now exists in terms of access to reproductive health care services, where abortion is no longer a right, but a privilege to women who live in 20 or so states. So for those of you who aren't familiar with medication abortion, what it and why this is still legal in certain contexts and presents a pathway forward, what it is a safe and legal and high quality way to terminate a pregnancy up until 12 weeks. And it can be safely administered both in person, but also prescribed virtually. And today, while only 1% of abortions are cared for in a primary care context, up to 90% of abortions actually could be cared for in a primary care context and eligible, so to speak, for medication abortion. And so while this is, I like to think of myself as a pragmatic optimist who looks at crises like this and saying, okay, what are we going to do about it? Every day, women are pregnant, become pregnant who don't want to be and need access to care. I'm really proud to be providing medication abortion on TIA's platform today in California and New York, where it's legal to do so, and paving a new way forward that represents abortion as a critical component of women's comprehensive health, paired with family planning, paired with physical health, paired with mental health, and the full basket of services that TIA provides.
Thank you, Carolyn. That's wonderful to hear, and it does provide a beam of solution and hope for at least a large proportion of women who may need this solution. Allison, how about you? How are you seeing this moment in time, and what are the ramifications for the system?
Again, I'm echoing that it's devastating, and I agree with what both Carol and Laurie just said. I think this is just another example of how society marginalizes women, and it's restricting their access to healthcare. As an emergency physician, I see the consequences of misappropriation of either, delivery of abortion care, or the consequences of what happens when women take it into their own hands. And just to echo one other statement, that was, I'm also concerned for the physicians, because we take an oath to do no harm. And, we spend so many years learning our craft and trying to do the best that we can. And then we have no regulatory power. So we have all of the risk in providing care for patients, but we don't really have any power in regulating, the healthcare system, really. So I think, it's just another example of us as physicians being also marginalized.
It's a really interesting perspective, and one to also think about, as Carolyn was mentioning, the expansion into primary care and the role they have to play, and what risk are they going to have to take on to support this. We're going to talk a little bit more about that later, but I want to lead into something you're also all bringing up, which is this is not a single person issue. Health equity in general is already has stark differences. It's not just about men versus women, it's women and women of different determinant backgrounds, and I think abortion is just one of the microcosms of highlighting that difference and disparity that we see overall in the healthcare of women. Allison, you've worked a lot studying health equity from early stage medical research, which you mentioned earlier, to provision of care downstream. Two questions for you. Where is the equity divide still most striking today? And then what progress are you seeing, are we making that we should be having?
Sure. And, where I think it's most striking is when you think about our entire understanding of conditions with high public health significance, so cardiovascular disease and stroke and cancer, and we think about who were the subjects used to study that. We are looking at men in their 20s, 30s, and 40s, and usually white, and have access to, to clinical trials and things like that. So if that's our entire understanding of health and disease, the more layers that you are outside of that, the compounding effect of the health inequities. So if we just take heart disease, for instance, and we say, okay, between men and women have higher mortality rates. They do worse than men. And then when you look within the women cohort, it's like, okay, now women of color do worse than white women having heart attacks. Okay, now let's add socioeconomic status and lack of access to healthcare. Let's add being a gender minority or your sexual orientation. All of these things are just compounding because our basic understanding was based on this one particular model. So I think, that really sort of cracks it wide open and really brings some of this to light. I think one of the things that we're seeing in progress for this are initiatives like the NIH, the Office of Research on Women's Health, for which I've been serving on the advisory board for many years. They have their own constraints and their own, power constrictions, but they're really working towards making sure that all of the institutes and centers that are funding research are really considering this, because this is not just about the Office of Research on Women's Health. This is about the office of, all of these other conditions and making sure that they are looking at these things. I also think one of the most really interesting things that are coming to light are looking at the physician and the patient concordance or discordance. So now this research is coming out that is showing that the sex or gender of your provider, how that affects your outcome as a patient. And I think that that's really going to just uncover so many, hidden biases. And so I look forward to more of that research coming out.
That research has been fantastic. Even some of the studies about the difference in gender roles in surgery and the outcomes that women have for male surgeons versus women in JAMA last December, I believe it was.
Exactly.
I mean, it's amazing to see. I do want to encourage the audience as we're talking, please feel free to ask us questions in the chat, and I'll chime them in throughout and save some time at the end. But, I also really like your highlighting the CV example. I mean, as a woman, I didn't even know that the symptoms were different for a heart attack, for example, until I looked it up myself, right? And I work in this field. So I think that there's a long way to go, not even on the physician side, but on the patient side, and recognizing the differences of what we hold as standard in our heads and how we're taught about it. Lori, do you have anything to add on this area of health equity? I know this is another passion area for you.
Yeah, definitely have more to add. I think as we think about the equity impacts, we also have to understand the impacts on racial equity and the intersectionality of gender and race and what that means. As we've seen with, the pandemic, just the inequities in terms of rates of contracting of COVID-19 and deaths from COVID-19. We see that Black and Indigenous Americans just have higher rates. And we have to, truly understand really why. And so I also think it's important to dive into some of the root causes of these reasons to better understand, because then we're not thinking about Band-Aid solutions. We're really thinking about comprehensive solutions. And, I like to sort of think of the 5 whys, and, for example, if we think about the high rates of maternal mortality, we know that, many of these rates, for example, in health conditions and excess maternal deaths are 60 to 70% preventable. So why do we see these inequities by race or among, for example, Black birthing people having higher maternal mortality rates due to cardiovascular disease? Why are Black birthing and pregnant people less likely than their white peers to receive quality low quality and low risk care based on standards, risk appropriate care that's not based on standards? Why do we have factors such as lack of access and poor quality care and sort of the inequities and the drivers of health? And so we really have to understand that. And at the end of those questions, we also have to understand the role of structural racism, the role of racial bias in terms of the provision of care and access to care. And we need to be able to address that in a meaningful way. There's a really interesting study in JAMA that just came out looking at sort of this disturbing pattern of racial inequities and COVID-19 and looking at pediatrics. And that goes to sort of the solutions. In addition to thinking about transforming the healthcare system, we also have to not forget that we also have to address, wealth building and the other drivers of health. And so that's why conversations about how do we use innovative methods of financing, how do we think about venture and philanthropy to really provide infrastructure and really provide true health within communities. I think those conversations are really important in addition to innovations in women's health, and addressing that intersectionality is critical.
And I do see the health system moving there more and more. I mean, we've known for years that only 10 to 20% of your health is determined on the basis of
exactly.
behavioral, environmental factors.
Right.
And we know race and income above all the social determinants of health are the two largest drivers. So we know this information. I do see this system and different stakeholders starting to act on that. So for example, in pharma, can we close it at a disease area level? Can we start to figure out where different things are happening? But all this amounts to something you were talking about earlier, Carolyn, which is, my personal situation, who I am as an individual is really what we're striving for. It's not just, across the baseline, this care of women overall. And so started talking about experience. You talk about women as the power buyers of health, people who are looking for an experience that can really be for them. Why are we still seeing this experience gap? And what can we do to create that better momentum? Because if we have better experience, we theoretically should also be engaging in a way that is also providing better outcomes.
Yes, absolutely. So hopefully by all the data that's been shared just in the last few minutes, it's clear that there is a moral imperative to make healthcare work better for women. But as you point out, there's also an economic one. We know that women control more than 80% of the US healthcare dollars. Not only do we spend more on our own care, but we make the bulk of the decisions on behalf of our children, partners, and parents. And why this is important is, yes, women's health outcomes unto themselves are in a very bad state, and we need to invest in them. But for payers, for health systems, for employers, for traditional buyers of healthcare, there's a loyalty crisis with they have a loyalty crisis with their most powerful customer. 50% of women distrust the US healthcare system. They feel dismissed, ignored, not heard. And so that's where you say, why does experience matter? Which in many ways is I think, one of TIA's core innovations of reinventing the experience of healthcare for women. Why does trust matter? Why does relationships matter? Women want someone, not something, to manage their health. They want one place to go where they can be cared for as a person, not a part, and seen, heard, and cared for. I often say that is our most simple but profound invention is listening to women, and you see it in all the data. And when women feel heard, they take care of their health, they're loyal, they make better decisions for themselves and their families. And it starts with an experience that listens to women. So what does that look like? We can talk about it and why the current healthcare system ignores women, doesn't work, doesn't make women feel heard. But what would a new experience that actually listens to women deeply, what does that look like? And I think it actually dovetails in many ways to the last question around health equity and intersectionality. I think when I look at, the tens of thousands of patients that we serve at TIA day in, day out, and their feedback on our care, it's this idea that we account for what we call the lived experience of the person, not the patient, in the exam room. How do we affirm and celebrate all aspects of one's identity, from gender identity and sexual orientation to race and ethnicity? How to create space for trauma sexual trauma in particular and trauma-informed care is something that TS specializes in. There's no detail that is too small from if and how we ask someone to get on a scale, or if they don't want to discuss their history of sexual trauma, or want all of these things go into in a quote unquote experience that gives a provider more inputs to then better able to diagnose and treat that person. And that's what we're starting to see, and where experience, we believe, is a key driver of better health outcomes for women. And ultimately rebuilding that trust that the healthcare system has lost with its most powerful customer.
I couldn't agree more. And you've opened up an issue we were going to talk about in a little while, but maybe I'll jump there now for a second, which is we can't just even talk about women as cisgender women. We have to talk about, women for who they are in terms of identity and what they experience. And Allison, this is a particular area that you've spent a lot of time researching and talking about. Can you share a bit more about why this is so important? You've also said that pharmacists play a particularly strong role potentially here in supporting understanding and experience. But can you tell a little bit more about gender and diversity?
Sure, absolutely. And I think it's really important to define the difference between sex and gender.
Yep.
Sex being, it's a biological variable, so anatomy, physiology, where gender is a sociocultural variable, and it could be changing and on a spectrum. Both of those variables affect health and disease. And so when we are doing research, we need to make sure that we ask the question, are we studying something that's a biological sex and that impact on say, like when you mentioned pharmacists, on say drug efficacy and safety? Are we talking about gender? Because then if you have someone who is transgender, then what I do and what I teach is I say, okay, well, let's look up the literature about what their biological sex is telling us that we should know. And then let's look up the literature about what their gender identity is telling us and what we should know. Then we can individualize that for patients. Now, one of the areas that I think is really also fascinating is looking at some of the pharmacy literature, is that when someone is transgender, or if they're taking exogenous hormones, so if they're actually taking gender affirming hormones, then the pharmacokinetics and the pharmacodynamics of metabolism of drugs changes over time to that of the gender that they're transforming into. So it's really interesting. So I think pharmacists can play a really key area here to help physicians understand how to prescribe appropriately, how to recommend different dosing during different parts of the menstrual cycle, how to make sure that people understand the different side effects depending on their biological sex or their gender identity. So this is something that we really need to embrace, not just when we're enrolling a subject or when we're taking care of a patient, what's their biological sex, what's their gender identity, but also what is their hormone status, because that is going to affect our understanding, especially of medications.
So I love where you're all going, because it isn't just about who I am, it's about the experience I've had and the experience I'm having right in this moment, in terms of where are all the parts of me that are showing up, that are affecting how I'm presenting, what I need next. And so talking so much about this issue, there are evolutions happening right now in the healthcare system that are affecting some of the frontline clinicians, whether it's the pharmacists and, lots of changes that are going on with pharmacy retail today, but also primary care. And you've all mentioned primary care in some way, shape, or form as a frontline that needs to be aware of this, not only of who the person is, but then everything that they're coming to the table with in that moment. Primary care, everywhere you look, you've got VCs buying up primary care, you have the CVSs of the world expanding, you have companies in femtech like Tia coming about, Lori, you've written extensively about community-oriented primary care and primary care innovation. What is your prediction? Is this change in what we're seeing in primary care going to help some of these important issues that we're talking about, going to help us recognize some of these differences in the person and going to help us push forward women's care?
First, I'd love to take off of what Allison mentioned.
Wow.
I think as we think about gender. We also have to, there's, an understanding sort of the biologic effects of gender and sex. We also have to understand the social dimensions, right? Which is kind of what I was talking about earlier, and really understand, based on structural issues within in the US, how the healthcare system treats people differently, how providers treat people differently, and how data supports people getting different outcomes. So for example, trans people in the US and in general minorities in the US face discrimination at every level, whether we're talking about barriers to education or housing, employment, or healthcare. And so when we're thinking about providing healthcare or transforming the healthcare system, it's recognizing those biases and creating a system that ensures that those biases are not allowed. So I just wanted to just elevate that as well, because it's also important to think about the social constructs in our society. To your question about—
Before you go there, I mean, I'm thinking about when you walk into the primary care office, what's the first thing as a biological woman you're asked is, when was your last period? How jarring and how hard is that for a trans person? I mean, it's really
right. I remember when my prior role, I was National Director of Reproductive Health at the VA, and sort of really working around systems transformation. Many people would tell me they'd come to the healthcare system and people would say, where's your father or where's your husband, without recognizing like that person served on the front lines and is coming to the healthcare system to receive care. So end to end, from, whoever's sort of seeing you at the front desk through the entire journey of care, we have to recognize these biases, our biases, and the systemic biases and racism built in, and address them intently.
Absolutely. So, so what is your answer then? I cut you off.
So for primary health care,
yeah. So I mean, you already,
so for primary health care, I mean, I'll just say briefly, primary health care, we know, is the foundation of a healthcare system, and we know that in the U.S. context, many people do not have a primary health care provider, and we do not have an intact primary healthcare system. Whether we're talking about, for example, maternal health outcomes, that's why I don't look at that in a very siloed way. We have to think about people's healthcare before and after. This is why I think like policies like Medicaid, postpartum extension, at least up to 1 year, is really important, because we're not saying, okay, after birth, you're done, peace out, bye-bye, you don't need any more healthcare. So when I think about primary healthcare, it's about integrating the mental and behavioral health into that. It's about addressing the drivers of health. It's about what are ways we can utilize technology. The front door could be my phone, it could be the computer screen, or it could be me going into the clinician and seeing someone face to face. And I use clinician broadly. I mean, I'm a physician, and also whether someone's seeing a nurse or a midwife or a psychologist or a psychiatrist, I'm using that term broadly in terms of the care team. And so that's how I define primary healthcare, and there's evidence to be able to support that as comprehensive primary healthcare.
We're putting a lot on primary care here, and intentionally as the front line, but you're right, 25% of Americans do not have a doctor.
But it's not just primary care physicians. It's not the one person. It's this care team, which is multiple people, which is really critical.
And we're asking them to do a lot because, it's this care team is not only, do they need to look at the whole person, they need to wrestle with the fact that medical information doubles every 73 days. So I'm treating an individual, but I'm also trying to keep up with everything that's going on about how I should treat that individual. And we talked about outcomes earlier. We're moving into a system where wellness and prevention is even more in focus. And so we're asking them to make sure that we're having our women well visits, that we're kind of really pushing people to stay on top of that. Carolyn, part of your organization's mission is actually driving a bit of that care from the earliest aspects of prevention. What do you see as important in this shift as we talk about this quest for redesigned care for women?
So I want to just touch briefly on the role of primary care for women as related to women's whole health, wellness, prevention, and so forth. So Lori called out the massive primary care shortage in this country, not just primary care physicians, as she mentioned, but a place to go, a touch point. For women, it's even more extreme. 50% of women don't have a primary care provider at all. It's really interesting for me in terms of my own journey. When I started TIA, I didn't set out to build, reinvent primary care for women at all. But that's what we've ended up doing. And I often say, women aren't looking for a PCP, so to speak. Go ask 10 women on the street, what is primary care? And you'll get 10 different answers or lots of question marks. What women are looking for is a relationship. They're looking for a medical home. They're looking for care for them as whole people. And so when he said, we're going to reinvent healthcare for women, part of our solution was saying, let's give women a primary care home. That's high quality and cost effective, that's accessible, convenient, and experience that affirms women's experience in the world. Let's not just be a triage function or revolving door. Let's think beyond just primary care physicians. Let's think about care teams and go deeper. So our medical home model includes gynecologists, it includes therapists, it includes psychiatric nurse practitioners, it includes acupuncturists, it includes pelvic floor physical therapists, and they all work together with care coordinators to coordinate a patient's care. And then it also connects deeply with specialty care beyond our four walls through health system partners. And so what we really do is we're creating a new ecosystem for women that connects primary and specialty care, virtual and in person, and saying that's primary care for women, not just a once a year physical or a CPT code or a certain type of family practice physician. So as it related to your question around prevention, why is that so important? In addition to addressing the primary care gap and reinventing the experience of women's health, we're very committed to shifting healthcare from just treating sickness to supporting wellness. And how do we do that? I often say women love wellness but hate healthcare. And what if we have rethought what is healthcare to be focused on well care? And that's so much of what we do. But again, we do it by saying, okay, wellness is more than you don't have cervical cancer, see you next year, or you don't have an STI, or you don't have this chronic condition. It's about mental health as an example, in helping women achieve their health goals, whatever that may be. So one example of that, we have reinvented what is considered your annual exam. So most people think of this as a pelvic exam or a breast exam. And instead deliver a whole person health exam that includes mental health screening for every patient. You get a cervical cancer screening every year. You should get a depression and anxiety screening every year. Women are diagnosed with depression and anxiety at 2 to 3 times the rate of men. One of the many areas of sort of underdiagnosed and misunderstood sex-specific difference that we think is core to address from a preventative perspective, not just a treatment perspective. And really thinking about giving women multiple tools in the toolkit to manage their health preventively and as well as when it comes to chronic conditions, autoimmune disorders, conditions like endometriosis and PCOS, postpartum care, where there are massive, massive gaps. We need to be giving women more tools that integrate traditional medical services and wellness services and wraparound support services like doulas and lactation counselors and so forth. All of these offerings can, I think, be leveraged together to give women more tools, but also offload that primary care physician who can't do it all. And there are not enough of them to go around. And that is where I think TIA's model really aims to sort of address some of the systemic issues that are underlying the primary care infrastructure gap in America.
I really love everything you said. I think that what I'm learning from the three of you today is that part of the solution to redesigning women's care is recognizing that it is about the whole person, but it's also not about any one piece of a solution. It's about bringing to the table all the different aspects of health and our lives in a very accessible way. It takes the village, right, to manage health. Allison, Lori, any thoughts on top of what Carolyn is saying?
I'm listening to Carolyn talk about this medical home, and it just sounds so wonderful because what I see in the emergency department is when that doesn't work. And so, I was taught to be very focused in my exams and in my problem solving, because they supposedly have this other person outside that's caring for their whole body. And so I can make the diagnosis and I can prescribe a treatment, but without them having, access to the money, or to be able to drive to pick it up, or to be able to have a follow-up. I can fix someone's blood pressure, but then, without someone checking it next week, it becomes irrelevant. So a lot of times we feel as though we're just spinning our wheels and putting patches and holes everywhere. So I definitely think that, having some medical home is critical, especially for women, I would say, because women are often misdiagnosed and underdiagnosed and referred to multiple specialists. So we were talking about cardiovascular disease and how you didn't, even you didn't realize that the symptoms are different. Well, neither does the EMT, neither does the triage nurse, neither does the doctor. And so what happens is, when we say, oh, you're not presenting like I was taught for, pattern recognition, I was like all my residency and pattern recognition. Well, the pattern, you don't fit it because you're not the man that we understood. So go to a gastroenterologist, it must be your stomach, and here's some medication. Go to a psychiatrist because it must be your anxiety. Here's some more medication. Go to a orthopedic doctor. And so someone needs to make sure that they have their hands on this for this patient, because it's hard for them to navigate on their own. And then, this is they just get lost into this health system. And so, I definitely think that that primary care plays a central role.
Oh, thank you for that, Lori. Go ahead, Hans.
Just to add to that, so at the VA healthcare system, as we were designing women's healthcare for women across sort of the national healthcare system, having this patient-centered medical home was really critical, right? And we were thinking of, we implemented women's health primary care providers. There's a storm here, I'm sorry. I don't know if my women's health medical providers and sort of a patient-centered medical home for women, to have an integrated care team, primary care provider, a nurse integrated with mental health. And then, the gynecologist as the specialist sort of, was available for specialty things, but a lot of that could have been taken care of in the medical home. And what the research showed was that women had better experiences, they had better outcomes, and they were more likely to receive key preventative services. So within a national healthcare system, implementing that model, there's already data showing that that's effective. So the second point is, I think, just putting my policy hat on, I think it's really important to think about the payment incentives that can drive the delivery system incentives. And so it's really critical, and which is really an exciting time, because there's a lot of conversation around primary healthcare and payment around primary healthcare and building primary healthcare. But you really need those payment incentives from CMS, from the federal government, to be able to drive that accountability and drive those delivery systems actually coming into fruition and really creating the system that we want to see.
Not to go down an economic and policy hole, but it is an important point. How you get paid for health and the construct we put around care makes a difference. And as one of our audience members pointed out, we're primarily fee for service, and that's probably driving, Allison, a lot of how we train and then how we operate in areas like you were talking about. Any comment on how that's affecting our ability to advance women's health?
Oh, I'm sorry, were you talking to me or Lori?
Go ahead, Allison.
I'm not sure if I understood the question.
Yeah, so you were talking about how we're trained and taught to focus on the specific issue of the moment, and actually our system is set up on a fee-for-service basis primarily. Okay. So even though there's evidence to say we need an integrated model, we need a medical care home, we need a TIA platform to bring us all together, the incentive is essentially to do what you were describing.
And that's a critical piece, because all of our charting and electronic medical records are all designed to make sure that there's a bill, that what we're doing is billable. So we've really lost the connection to the outcomes for the patient, and I think that that's something that's definitely part of this. And we talked about there not being enough primary care physicians because they're not really valued as much as they should be. The more specialized you are, the more money that you are compensated for. And so when you look at who goes into which specialties, you can also see that women go into primary care more likely. They go into pediatrics more likely. Those are the lower paid salaries for physicians as well. So I think the more that I learn, the more I realize that being women's issues as patients and then women's issues in the workforce are very similar. They're very integrated. So it's the lack of value and how that value translates to money really is what's been the driver.
Oh, that's great. Knowing that we have about 10 minutes left, I'd like to talk more about solutions. And, I'd love to acknowledge one member of our audience said, women's health is narrowing. We're really solutioning for healthcare for women. And I think you've all been pointing to that today. So as we solution for healthcare women, maybe you can each give me, in one or two sentences, what is the goal? Like, what is it? How are we going to know we got there? What does success look like when we say, we've redesigned healthcare for women? Carolyn, do you want to go first?
Oh, this is like the subject of me, my co-founders' late night debates for the last 5 years when we talk about quality metrics and what success looks like and things like this. I think it's a few different things. One is really around access and ensuring that all women have, we can, address the access gap. That means people, all women can have access to a primary care model conveniently, affordably, and accessibly. We just have a massive supply gap there, as I mentioned, in so many dimensions that we need to work to fill. The second is thinking about more traditional clinical quality metrics. There's data upon data with respect to the harrowing outcomes that are getting worse and not better with respect to almost every metric that matters, maternal mortality being the standout one, but cardiovascular disease, mental health, chronic diseases, it goes on, and we should be actively looking at trajectory sort of reductions in these poor outcomes, or I should say improvements in these outcome metrics from a clinical quality perspective, earlier diagnosis being one big piece of this, and better treatment with maternal mortality being the number one thing on the list from my perspective. And then third is more experiential. I think we'll know how do women feel about healthcare? Do we think about women trust the healthcare system if women are actually engaging in their preventative health, looking at utilization data and experience data around trust? We'll know we've actually are delivering a product that women want and is serving women's needs.
Wonderful. Lori, do you want to go next?
Sure. That's a tough question. It is something I think about a lot. And, I always want to center the person in that question, because often we think about the audience as policymakers or payers, but ultimately we're trying to improve care for people. So I'd say the 3 Ps, people, payment, and practice / systems. I think for people, we want to ensure that people are seeing themselves in their healthcare providers. They're receiving the care that they're asking for. They're having a good experience and receiving high quality outcomes. I think policies, we know that investing in gender-centered care benefits everyone, and we need our policies to center that. And there are a range of policies that are in play that are addressing some of those issues. And then practice, systems, we want our systems to provide equitable, high quality care, really address systemic racism and bias, and ensure that there are no inequitable outcomes.
Great, thank you so much. Allison?
You said 1 or 2 sentences, so because this is a hard question, and I started with the gap being that I wanted to make sure research took into account women's unique physiology and social cultural points of view, and the goal would be that could be achieved, and I think that for me that is really about quickening the pace from the research that's happening to the bedside. So right now, that's such a long lifespan. It's such a long process to get, the right way of analyzing something and get that research. And then we have that. And then how do we get the awareness of that out to change, so that women get better care today. And so, I think that for me, success would be not only to have each of those areas, research and clinical practice, and then education, take all this into account, but that it's a much faster step. And I think maybe with more technology, we'll actually get there.
I think speed is really critical, speed and scale,
Yeah.
which you've talked about quite a bit in all of your answers. There's a couple of questions that I think we absolutely should answer. So I'll maybe ask one of you to just jump in when passion strikes. But what can healthcare systems do to demonstrate that they are in fact listening to women and building their trust? Are there any you see doing it well?
Well, I will jump in and start here and speak from in a bit of a self-serving way, but really think we have found a lot of success with traditional buyers of healthcare, namely health systems, who see what we see, that the healthcare system isn't serving women, that they have a sort of a trust or loyalty crisis. They need to fill in that primary care gap and saying, okay, how can I partner with organizations who are doing this, who are designed by and for women like TIA, to create a women-specific care model that can partner with them to integrate primary and specialty care. And we're really excited to be doing this. Partners like Dignity Health and UCSF in San Francisco. So I think, just to summarize, I think some say, okay, let me try to do it. Let's try to either we recognize the problem. Should we try to address this by continuing to push for a one size fits most primary care strategy? Or should I say recognize that we need personalized models, and let's find partnerships with organizations who are designed to do just that in a way that, frankly, traditional players aren't built for.
Wonderful, thank you. As advocates for patients and for people, another question is, how can we better communicate about women, healthcare for women, and about health equity, in this particular topic? How can we communicate about it and garner ideas then for action in our respective workplaces?
I can comment on that, because one of the things that I try to do is empower everyone to use their sphere of influence. So to broaden their awareness. So if you are, if you are someone who's on a curriculum committee, or if you are a CEO of a nonprofit or for-profit, or is to make sure that women are part of the workforce, part of the leadership, and then make sure that this is discussed. So so say you're not any of those things, and you're going to see your doctor. Your sphere of influence could be just asking your doctor, hey, is this prescription designed for me as a woman, or should I know something specific about this? That sort of will then educate that particular physician of like, oh yes, maybe I should look that up. And then now that they'll know that for the future. So I really think being very vocal about it, making sure that we have women in more leadership positions that can, women, it's been shown in research, women think of women's issues. So just having women researchers, that women researchers are more likely to do gender specific analysis. Women physicians are more likely to think of women patients. And so I think just having that cross-cutting nature, and then having everybody really feel as though that they can make a difference, no matter whatever their role is.
Whenever we also have conversations around equity, we also need to think broadly about equity, gender equity, intersectionality, LGBTQ. And so it's always being able to center various groups. The other piece to that question, I think it's really important to for allyship as well, but also being able to recognize and call out inequities as they're happening, I think is really important. And then also being integrated within systems. When we're thinking about quality and safety, we also have to understand that equity is a part of that, and really ensuring that we're really integrating all of these conversations and not leaving any one thing out.
Ladies, I have really enjoyed so much of what we talked about. I think we've landed on a couple of realities that changing healthcare for women means increasing the experience in closing the gap on outcomes and in making sure that there is a strong trust in the system to allow us to do everything we need to do. That requires us to think from the very early stages of what we're doing and how we're learning all the way through to practice. And also ensuring that we're constantly listening to the voice of the very people and the experiences they've had that are in front of us, making this more personalized. I can tell from the questions we've been asked that there are many passionate women on this call. There are also some passionate men who are here thinking of the women in their lives and of the women that they work with. Maybe we can just close out by having each of you answer one more question for me. For all of us out there, what is the advice of what we can be doing every day, to help redesign or help close this gap for women in healthcare? Carolyn, do you want to go first? I think you're on mute.
I think that what a great last question to ask there. So I think the most important thing, going back to in the context of post-Roe America, in many ways, this is top of mind for me, is to be body literate and to be your own advocate. I think we have a lot of work to do on the system side to improve the way healthcare is delivered for women, but there's a lot of deep problems, and it requires women taking control of their own health and being their own advocate. And to highlight what Lori said, I think there's privilege in being your own advocate. And so for those who face extra barriers, being advocates for other women, and I believe in a bottoms-up driven healthcare system with women supporting other women, in addition to providers, policymakers, health systems, and so forth. And I think we need bottoms-up healthcare now more than ever.
Love that. Allison, you want to go next?
Yeah, I wanted to echo, because I say that a lot too, Carolyn, with being an advocate, because it's very important, and it changes the trajectory of the course of a physician encounter when you have an advocate there with you that says, no, she's not always like this. No, this is not her panic attack. No, this is, not, just really sort of advocating, being very much educated as much as you can, and asking a lot of questions. So I think that we should feel like there is not a dictatorship anymore between a doctor and a patient, that they are a very well-informed, well-educated advisor. And so we really need to be empowered to understand what our medical record holds, to keep track of what tests and what medications that we've been doing. So I think we really need to encourage that that this is something that we should really embrace ourselves, to feel empowered, to ask lots of questions, and to bring or be an advocate.
Love that too. Lori?
Yeah, I'd like to really go from the systems and the accountability aspect, because I think we rely too much on the individual as they have to do this. I mean, as we talked about the pay inequities, sort of the gender inequities, and then on top of that, there's the individuals and now having to fight the system. So how can we create systems that have accountability? I think ultimately we should, hope for systems where we don't need we don't need advocates to keep people safe. The systems are designed in a way that that keep people safe. So I also think about it as top down, bottom up, and so one top down, the policies and the payment systems that drive the accountability. And while that's trickling down, bottoms up is really thinking about what is innovative financing from a venture philanthropy perspective that can really drive change at the community level and really bring healthcare back into the hands of the community.
As one woman sitting in the middle of that bottoms up and top down, maybe one thing I'll add is that it is in our nature, it is in the way the healthcare systems train us to think about when we're sick, how to handle it. And I think all of us need to individually, and for those we're caring for and those in our lives, open our eyes to what does wellness really mean? And how do we move towards that holistic care of ourselves, and what we need in the moment. But I just want to say thank you again, Lori, Carolyn, Allison. This has been such a wonderful discussion. Thank you to our audience for listening, and thank you to Health, of course. We are all on the charge to redesign healthcare for women, and you have an opportunity to do so in your world as well. So thank you. We hope this has been inspiring, and we'll see you soon. I know.
Thank you to Maria and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.